I'm going to start out my my talk today with a story, and I can almost guarantee that 99% of you are going to be able to relate to this story. So about 3-4 years ago, I was a specialty director at perioperative services, and I had like 9 cost centers. And I like to get in at 6 o'clock in the morning. I like to have my cup of coffee. It was quiet. I put on some music, and I looked at my schedule, realizing my schedule wasn't going to be that schedule for the day. And then I looked at my emails, and I just had a half an hour of David time. And I really enjoyed that time because I don't have any children. But that was me time. So cardiac huddle started at 6:30, and the other huddle started at 6:45. So I always had a half hour before. So I'm sitting there and I'm enjoying my morning, and I'm looking at my emails and my schedule, and my phone rings. It's one of our cardiac surgeons, Dr. Helkos, young gentleman, not malicious at all, very collaborative. And he calls me and he says, "David, we had to bring back bleeder last night. The call team is here all night. They're exhausted. They're going home. We have 4 cardiac rooms going all day. I got 3 in-house patients that have to be done within the next 24 hours. Where are you going to find me more CVOR nurses?" This is at 6:05 in the morning. Who here has experienced that with a surgeon? Okay, and you're like, okay, it's 6:05. Let me get my mind together. And I said, "Well, Dr. Helkos, I love this part too. Oh, and by the way, I wanted to let you know that I already called the CEO of the hospital and let her know what was going on." I'm like, "I'm really glad you did, because I know in her cell phone, she has at least 6 to 8 experienced cardiac nurses she's going to call in for us today." I didn't really say that. I could have said that to him though, because he's such a wonderful man. So I said, "Dr. Helkos, we're going to continue to have this conversation over and over again, because I'm not going to be able to just fabricate these nurses." I said, "I need your help." He goes, "Well, what are we going to do?" And I said, "Well, I tell you what." I said, I recently looked at a Periop 202 program for orthopedic and spine that was created by AORN in a collaboration with the Orthopedic and Spine Pavilion out west. And I said, it really is a nice program. I said, the graphics, everything is wonderful. It's all evidence-based, and I said, it's just really nicely done. And I said, I would like to approach AORN and say, can we make one for CVOR? And he said, well, what do I got to do? I said, well, I want you to be on the team, the multidisciplinary team, and I want your input, and I want some resources from you, and I want your support, because you're going to have to go tame these doctors and let them know what we're doing. He goes, okay. Are we going to get any money for this? I said, no, you're not going to get any more money for this, Dr. Helkos, but you're going to get the satisfaction of helping nurses. He goes, okay. He actually did. He invited us to his office. He gave us textbooks. He looked over our curriculum. He was very engaged. So then I went out to a roundtable meeting in Denver, and I was having dinner with Linda Grohl and Susan Bakewell. Very good opportunity. And I said, hey, I've got an engaged CVOR team, and we really love your orthopedic 202. Can we possibly do one for cardiac? And you should have seen Linda and Susan are like, you're kidding. Of course you can. So that's how we started our story. So that's why I'm here today, to share that with you. No actual or potential conflicts of interest in relation to this program or presentation. The learning objectives: the learner can identify the need to employ a significant number of OR nurses to meet the demands of the OR. The learner will be able to learn interventions for recruiting and retaining OR nurses. The learner will be able to describe how self-efficacy can aid CVOR nurses' core competencies, protocols, guidelines, and open power procedures, and to function on the CVOR team. So this is Emory Healthcare. This is where I work. Emory Healthcare is part of Emory University. It's the most extensive healthcare system in Georgia. We're located in Atlanta. We are made up of 11 hospitals and Emory clinics, more than 250 provider locations, largest clinically integrated network in Georgia. More than 2,800 physicians concentrating in 70 different specialties, and of course, cardiovascular surgery is one of them. The top one is Emory Midtown. That's downtown, right in Midtown. Is Taviana still here? Taviana still here? Okay, she was oh, there she is. Hey, but that's Taviana. She's the special director at Midtown. So that's a big hospital. They do cardiac surgery. So they were part of the pilot. Emory St. Joseph's. I know Angeline's here. Joyce is here. They're northwest of Atlanta. And then Emory University Hospital is right on the campus on Clifton Road. These are the 3 hospitals that participated in this program and data collection with AORN. A little bit of background and significance. Again, we have a global aging population. This morning, I just looked up the underneath ACL.gov. It's like people 65 and older is about 16.9% today. And in 2050, it's going to be 22%. So we're all getting older. Just want to let you know that. Aging workforce of especially nurses. I think the average nurse's age is what, 44, 45? Is it higher than that? Okay. It just seems so young. I don't know why. 44 seems so young. Anyway, so we have the aging workforce. We have an operating room work environment, which we will get to, okay? Very staticky. Increased turnover of specialty nurses, of course. Usage of traveling nurses. We're all hemorrhaging millions and millions and millions of dollars on traveling nurses. Operating room contributes 60 to 70% of the hospital's revenue. Our system CEO had told us one time, it was hilarious. He goes, without the operating rooms functioning, just lock the doors and put on an out of business sign on the doors, because we are not going to be able to make it without the revenue of the operating rooms, period. So that's how important we are. And you know, when you realize that every day when you get your OR schedule, you have the board of directors, you have the C-suite, you have the surgeons, everybody's looking at your OR schedule. What are you doing? What's going on? Who's on vacation? Who's not on vacation? Hey, do we have an extra robot for you? And they watch every single thing we do, because we are the big revenue maker. Okay, we are the ATM machine. So they pay attention to this. So the CFOs are very attentive to what's going on as well. And then interventions aimed at increasing and recruiting and retention. Identifying the problem, of course, you know, aging global population, increasing demand on surgical services, not only for CVOR, but orthopedics, for everything. We're going to need more surgical services. Global shortages of surgical nurses. And then Periop nursing curriculum lacking in undergraduate programs. Doreen, you are correct. I'm so glad that you are working to bring nurses into the operating room. I appreciate that. But we have a long way to go. We still are not there with the BSN or even the ADN, bringing these nurses into the ORs as clinical rotations. And then recruitment challenges for high demand and specialty nurses. Review the literature. Of course, the 3 major factors causing OR staffing shortages was one of our literature searches. Aging population of OR nurses, little to no exposure to periop clinical settings in the undergrad curriculum, complicated and intimidating surgical environment. We all know what that complicated and intimidating surgical environment is. And if you are not dealing with it, you have a big problem. I know Vanjie and Angela talk about bullying. They speak about bullying. I just listened to Vanjie last week in Boston talk about bullying. Really good information, Vanjie. Thank you. Dr. Petrozzini, in incivility in the OR, she's done research and she did her DNP program, incivility in the OR. So thank you for doing that as well. Leslie, I appreciate it. It's happening. So you go to the physicians and you say, okay, we can recruit them, but you have to retain them. Okay, this is a new program. So if there's somebody new in your room, you better welcome them and ask them, you know, if they have any questions, let me know. And so that was Dr. Helko's job. That was his job, to introduce people and to make sure they were comfortable. Our project goals were to increase the knowledge of nurses who are new to the CVOR, increase self-efficacy, making them feel more comfortable, new OR CVOR nurses to function on the CVOR team, to determine if an educational intervention improves CVOR competencies that are based on the AOR and guidelines for perioperative practice, to determine new CVOR nurses' satisfaction with the CVOR Periop 202 program for open heart procedures. So our project development, we used the Iowa model. It was like a glove. It fit our project nicely. The Iowa model basically is evidence-based practice to promote quality care, really guided the design. We identified the problem right up front. We recognized the opportunity. We stated a purpose with asking a question. We formed a multidisciplinary team, and our multidisciplinary team, I'll get to in a few slides, but it was circulating nurses, surgical techs, unit educators. We had a CVICU nurse that was there to accept the patient. She was involved. It was truly a multidisciplinary team. Finding and appraising evidence relating to the topic, designing and testing the change, which we did, incorporating the change into practice long-term, of course, and then sharing the results and dissemination, which I'm doing today. The curriculum design, with support of Periop 101, Susan Bakewell and I were on the phone back and forth 20 million times during this process, but we truly had a true collaboration with our team and AORN. The classroom content was, we had goals and objectives. We had reading assignments, supplemental videos, PowerPoint presentations, module post-tests, and proctored final questionnaire. We had clinical skill labs involving committee members. So those committee members that were on the committee were actually in the operating room with these folks. Established clinical objectives, competency assessment, and sample course schedules. Now, I will tell you that we tried this with 3 months, and when we initially initiated this, it was October, November, and December, bad time of the year to initiate this creative platform, because, you know, surgical volumes are up, everybody's urine deductibles up, call-offs, FMLAs. It was a disaster, but we got through it. We got through it. I mean, there was a lot of discussion, but we got people through the OR, to the CVOR. So how many here have actually went on to Periop 202 orthopedic and spine and looked at that program? Yeah, is it just amazing? I mean, the graphics, this is not something boring. This is something that even as a nurse of 35 years, you're like, oh, that's what they do. You know, I mean, it's amazing. It's not boring at all. So this curriculum is introductions. You know, what's the purpose? We share the information. What's the history of cardiac surgery? Why are we doing cardiac surgery? So we go back in history. We have learning outcomes, learning objectives based on the QSIN competencies. We have a cardiovascular glossary where you go and you can actually have 2 pages of common terms that you're going to hear in the CVOR. You can actually print that off and take it in the OR if you choose to print it. Anatomy of the heart. I'll show you in the next slide. The graphics are amazing, and you touch all these this anatomy, and it pops up what they are in different locations, what they do. CABG surgical procedures. We have live videos of CABGs on pump, going on pump, off pump. Preparing the operating room. What are you going to need to set up for a basic CABG? What is your equipment and your OR supplies? And then post-operative care. Okay, what are we going to do? The CVICU nurse was there, and she said, this is what I'm going to ask you for a report. So we put that in there. Summary, final assessment, results, and next steps. Again, I really took these pictures for the modules, but it would not allow me to put it in here and show you. I really want to do that because there is a whole bunch of dots on this anatomy, and you just touch that dot and it just boop, you know, and it just you get to know the anatomy. And some of the nurses that have been nursing for years are like, why didn't we have this when I was going to school? She goes, this is amazing. I said, really is it? It's actually fun. Same thing, all the vessels of the body. And then, for example, the major vessels of the heart, you're going to have one bypass. You're going to do what? From the aorta to what? The circumflex, which is all the way at the bottom. So it tells you exactly where you're going to go. Room setup, you know, curriculums, again, room setup. So this is what a typical room should look like. If someone tells you to make sure you have everything in the room for a CABG, this is what you're going to need. And then during the procedure, it actually shows the beating of the heart, shows them with, like I said, cannulating and all that. So it actually shows you on these modules in live, it actually shows you the heart-lung machine going and what the heart-lung machine does and the importance of the heart-lung machine. And I really wish I could have shared that with you, but it just wouldn't do it. It wouldn't allow me to do it. We'd be up here for 45 minutes trying to figure it out. But I would encourage you to review it. Project implementation and tools. So self-efficacy for interprofessional experiential learning, SEIEL tool to be utilized. Pre and post Periop 2 to educational intervention based on the 8 CVOR content modules. It's a 16 Likert scale, 1 to 10. CVOR questionnaire was a pre and post Periop 2 to educational intervention, again, based on the CVOR content modules, 20 multiple choice questions. We created a competency checklist, and then we did reflective journaling for the nurses, which I'll get to in a minute. This is just one page of the competency checklist. There's several pages. And you know, it starts with avant-garde, it goes all through the SCIP initiatives. I mean, it's very balanced, but it just check. So basically, what you've learned in your 101 or what you learned as a nurse in the main OR, you're going to be using that. Plus, you're going to be learning more techniques in CVOR. Stay interviews. These were fun. So basically, they were used to identify common themes regarding CVOR 2 program experiences. Connect with participants to assess their engagement in the program. Keeping a journal allowed the new CVOR nurses to write down their thoughts about the program, the opportunity to vent frustrations and savor accomplishments, and then the perception of the experience during the program. They really enjoyed this. They each had like a little booklet that they wrote down their comments and their thoughts during the procedure. That was pretty powerful because that was a huge connection, and you could really connect the dots between all 17 of these nurses that went through. You also find out who your shining stars are and who your prickly pears are. I don't really want to participate. You need to deal with that prickly pear, I'm telling you right now. That's all I'm going to say. So the stay interviews, reflective journals, again, that was so important. It was basically connect at the Periop 2 candidates to determine the degree to which they are engaged and planning to stay. Now that was the big joke, was they're like, really? This has only been for 3 months. What are you talking about? I'm not, I can't talk about that, which is, it was sort of fun. But the interview was meant to be informal and not part of their performance review. Allows the primary investigator, which was myself, to ensure these Periop 2 candidates know that they are a valuable part of the team. That's important, valuable part of the team. Questions were like, what did you like most about the CVOR experience? What parts of your experience were fun? Did you have fun in the room? And believe it or not, they did have fun. They enjoyed the bantering of the team that went back and forth. What about your experiences less positive, most challenging? Do you feel you've been recognized by other CVOR employees for your accomplishments? How do you like the CVOR team? Are they providing support you need? Have you ever thought about leaving? And that was the chuckle of the day. And how well are you using your basic OR skills and experience? Meaning what you learned in Periop 101, how much of that are you using? Of course, the correct answer was all of it. And what could we do better to make a difference or contribute? And then we talked a little bit about career goals. Do they want to be an RNFA? Do they want to be a first assistant? What do they want to be when they grow up? And then, of course, how can I help you stay on the CVOR team? The questionnaire was 20 multiple choice questions, assess content that came directly from the online modules. Okay, so these questions came directly from the modules. The CVOR team members, again, circulating nurses, surgical techs, Periop educator, shift nurse manager, developed the modules and questionnaire in collaboration with the director of education at AORN. The surgical techs were amazing. They went in, they took pictures of their back table. They took pictures of internal defibrillator paddles. They took pictures of grafting tray. So with your back table, your internal paddles, and your grafting tray, you are now ready to do a cabbage. It was that simple. But the surgical techs owned that. Her name is Ashiki, and she's fabulous. So she was part of our team. And then, of course, the CVOR questionnaire was taken pre and post education. Scoring was 0% to 100%, and the higher scores indicated a greater CVOR knowledge. Pretty basic. There's 2 subscales in the self-efficacy. The first one was interprofessional interaction, and there were 8 questions relating to that. And then the second subscale was interprofessional team evaluation and feedback. Again, they listed all the objectives for the subscale. And then we got the pre and post scores for that. Program evaluation, we used descriptive statistics using Microsoft Excel 2016. CVOR knowledge questionnaire, the pre-intervention was 63%. The post-intervention was 80%. The SEIEL scale, again, subscale 1, interprofessional interaction, subscale 2, interprofessional team evaluation and feedback. The mean scores for both subscales increased in all categories from pre to post. Okay, that tells you something right there. The stay interviews feedback was, that was a lot of fun. That went right back to the team. I went back to Dr. Helco's. Feedback was a CVOR Periop 202 was too new for them to make any major decisions, but they really did express enjoying the new exposure. They enjoyed the learning the new roles, watching everybody do their roles. It was funny how they said that the team was so in sync with each other that when they were going on pump, off pump, very little verbiage, but everybody was doing their tasks because they are so in sync with each other. But it was all safe, and it was really, they just were amazed with the synchrony of the team. Challenges were not knowing what to do. Nobody likes that, right? And the fear of the unknown. What if we have to crash and go on bypass? Or what do we have to cannulate femorally because we can't cannulate through the aorta? Or what if to use the defibrillator? Stuff like that. Those are the concerns. And then just being a novice overall, being a novice is never comfortable for anybody. So discussion, again, support and guidance for AORN. Again, I can't tell you how we were connected. We were too connected with AORN. I mean, we were like back and forth and back and forth. Project manager basically piloted the learning modules using nurse self-efficacy tools, assess new CVOR nurses' knowledge and competence and satisfaction. A multidisciplinary team open to sharing knowledge, creating positive learning environments conducive to adult learning. That was very important. They were all connected. Utilization of the Periop 101 course allowed expansion of learning in Periop nursing. So basically taking the Periop 101 and then adding to that foundation of practice. Implications for practice, where do you want to start? There's so many. CVOR nurses shortage, increased surgical volumes, travel nurse usage, the need to create and implement a CVOR orientation program. If you think that this program will eliminate your travelers in the OR, you're in the wrong place. Mr. or Mrs. CFO, they're like, well, is this how, what's this going to do with the reduction in travelers? I'm like, whoa, slow down, slow down. That's the first thing they want to get rid of. They provide healthcare assistants with an evidence-based tool to recruit and retain new nurses interested in CVOR. I had nurses that said, you know what, I'm not sure about being in the CVOR team, but I would like to know how to go in there and give breaks and lunches, and I might think about it. Okay, perfect opportunity. Program supports increased confidence levels and allows nurses to reflect on past knowledge and what they need to learn. They realize there's a huge gap in what they need to learn, but they're learning it in a safe environment with a safe team and a evidence-based program. Conclusion, aging workforce, both local and nationally. Operating room curriculum lacking in undergraduate programs. We're just scratching the surface with that. Operating room environment does not support new nurses to the specialty line. We all know that. 30 to 50% traveling nurses in CVR. If you got 30, 50%, that's probably conservative. You might have more than that. CVR nursing retention is low. We threw in the 2019 National Patient Safety Goals because preventing mistakes in surgery, if you have contracts every 13 weeks, you have travelers in and out, there's real safety issues with that. And then the Periop 202 program was developed and approved by AORN. That's very important that everybody understand that, to begin to increase knowledge and self-efficacy in nurses orienting to the CVOR. And this is my information. We were published in AORN Journal 114. All of our addendums, all of our sheets, all of our evaluations, everything is in this in this article, and you're more than welcome to read it. And again, this is my information, so you can email me or get my cell number, and we could chat later. But I'd like to thank, Dr. Settler and Moore and Dr. Green. They helped me with this project as well, and some references. And thank you.